Good afternoon and good morning to those folks joining us in the western part of the state. My name's Jessica Elliott, and I'm a Quality Improvement Advisor here at the Kentucky Regional Extension Center. Now, before we get started, just a quick reminder that the information contained in this presentation is for general information purposes only and does not attempt to provide medical, mental health, or any other type of healthcare service. This presentation is not intended to be an alternative to medical treatment, and the content of this webinar may not apply directly to specific circumstances. The information is provided by UK Healthcare's Kentucky Regional Extension Center, and while we endeavor to keep the information up to date and correct, we make no representations or warranties of any kind, express or implied, about the completeness, accuracy, reliability, or suitability with respect to content. So we are pleased to bring you our Year 7 Educational Highlights Roundtable. We have the entire Quality and Value team on our call today to help answer some of your most commonly asked QPP questions for this current performance year. Just a couple reminders. We will be sending out a recording of this webinar to all attendees here over the next couple of weeks. And then if you do happen to have any questions during today's presentation, we will provide our contact information for you at the end of the webinar. So, and just a reminder, here at the Regional Extension Center, our goal is to be your trusted advisor and partner across the state of Kentucky and beyond. Please feel free to reach out to us around any questions that you have regarding some of the outpatient or hospital inpatient services that we do provide. And now, again, I am joined on today's webinar by my fellow advisors, Robin Kernel, Vance Drakeford, Alicia Anderson, Jared Deason, Vicki Harden, and Tabitha Hanlon, representing all areas and practices across the state. Now, just as we get started, I want to just call a couple things to everyone's attention. We've had a lot coming out of CMS lately. And so I just wanted to put on everyone's horizon that the 2022 MIPS performance year data validation audit season is now officially open. CMS released a notice starting in November of this current month actually, through March of 24. They are going to be sending out notices for data validation for those who submitted for the 2022 performance year. Just to keep in mind, you do have 45 days from the date of notice, not the date that you received the notice, but the date that CMS sent it out to respond with any requested documentation. You will also note that practices will receive email notifications from Guidehouse. It does not come directly from CMS, so it is something that could be easily overlooked. Additionally, on November 2nd, so just a couple weeks ago, CMS released the physician fee schedule final rule that impacts performance year 2024 and beyond. So we're finding out some of the different thresholds, any adjustments potentially to that. This rule also covers the promoting interoperability, some reporting changes and timeframes. It also is going to cover what they have finalized for data completeness thresholds through 2026, plus a lot more topics that are very important for us across the state to be well versed in. We will have a client rule first look webinar. So this is a client only webinar that's going to be available on December 12th from 12 to 1 p.m. Eastern. And then a final reminder, for any of those folks who are interested in or need to apply for an extreme and uncontrollable circumstances hardship, the COVID-19 hardship for the EUC is still available for 2023, and that's at an individual category level that you can apply for that hardship. The deadline for that, though, is January 2nd at 8 p.m. Eastern, so definitely want to keep that on your radar if you are intending to not submit for certain categories and require that EUC. So today's topic is going to really focus on just a couple different areas. First and foremost, we're going to talk about eligibility and just the general participation overview amongst the different tracks of the quality payment program. We're also going to spend some time on MVPs and then as well as each of the different 4 performance category highlights across the program. So now as we get started, let's take a look at eligibility and participation in the quality payment program. And so first I want to direct some of our most commonly asked questions to our advisors, Tabitha and Vance. So I wanted you all to talk with us a little bit about how clinicians and organizations can participate in the QPP. What is that eligibility criteria and some of those requirements?
I think first, Jess, you have to determine if the clinician is in your practice or CMS deemed eligible clinician types. Those are listed in the middle of the slide in the gray box there. And then next, the EC must exceed all of those 3 low volume threshold levels. And for the MIPS track, those are going to be 90,000 in Part B billing, 200 Medicare patients, and 200 professional services. So if the clinician meets or exceeds each one of these, then they are required to participate, or as CMS states, they're eligible.
Two, also, some clinicians may not meet all of those low volume thresholds. They may only meet 1 or 2. And in that case, you can be opt-in eligible and you would be allowed to participate if you choose to do so. Just remember that if you do decide to participate and submit data as an opt-in clinician, you cannot reverse that once data has been submitted.
No, I think that's a good point to highlight, especially about that opt-in piece. So Vance, I have a follow-up question for you. How does CMS actually determine if a clinician has met that low volume threshold?
Okay. Well, first, CMS is going to look at the 10 NPI combo on the claims data that is submitted at 2 different segments of time, and they're going to analyze that and determine that eligibility. So, for example, for 2023 performance period, CMS looked at October 1st of 2021 through September 30th of 2022 and got what they call initial eligibility. And that is made available in December of 2022. Now, the second segment that they look at is from that October 1st of 2022 through September 30th of 2023 to determine that final eligibility. And that's released sometime in November of 2023. So at that point, that clinician has to exceed all 3 low volume thresholds in both segments in order to be deemed MIPS eligible.
So now I know that there are a lot of different options and different pathways for practices to be able to participate in the quality payment program. Tabitha, do you have any recommendations that you'd like to share with practices on how to really go about evaluating that choice and that decision?
Sure. It's up to you to decide which track of the QPP that you'd like to participate in. And you're also allowed to participate in multiple tracks as well if that's something that you would like to do. The most widely used track is the traditional MIPS track, and that also includes your MIPS value pathways. So with this track, based on the data that you submit, you would be scored on the 4 performance categories. And as we know, those are quality, PI, improvement activities, and cost. And one more thing, if you're eligible at the individual and group level, you can submit both ways, and then you would receive the payment adjustment for whichever score is the highest. And you can also participate via the APP by being in an APM or advanced APM. And then you would submit data according to the APM guidelines that you are a part of.
Okay, thank you. So thresholds and category weights. I know this is has been a level of anxiety for a lot of our clients, and most of our clients do participate and use the MIPS track for these thresholds. Is there a certain score that you always try to have your practices hit so that they can avoid penalties and make sure they're sustaining that high level of performance?
I'll go ahead and take this. Yeah, that's probably one of our most popular questions. So for 2023, this performance year, participants have to reach a minimum of 75 points out of 100 to avoid a negative payment adjustment. Anything below that 75 points, they will see some level of negative adjustment. And the lower the score, then the greater the negative adjustment is going to be. And that can be all the way up to a negative 9%.
That's right, Vance. And then on the other hand, anything above 75 points, is those that get that score are going to receive some level of positive payment adjustment. And again, the higher the score, the greater the positive adjustment is going to be. And that's going to be up to a positive 9%.
And I was going to say, with the feedback from 2022, I think we finally started to see there are definitely more losers funding that budget neutral piece of the program, so that there's more in the pot to be shared whenever you are maximizing your performance above that 75%. We're starting to finally see some larger positive adjustments.
Yeah.
All righty, so let's transition over, and thank you, Vance and Tabitha, for that. Let's transition over to MVP, so MIPS value pathways. This is a newer track. This is the very first year that it's been open for practices to participate in. So, Jared, do you mind to talk with us a little bit about how MVPs differ from that traditional MIPS track that we're so used to?
Yeah, certainly, Jessica. So as just mentioned, MVPs are this newest reporting option available. And really how it differs from traditional MIPS is MVPs offer a subset of measures and activities relevant to specific specialties or medical conditions. Unlike traditional MIPS, within your selected MVP, eligible clinicians will choose just 4 quality measures instead of 6. One of those will still have to be that high priority or outcome measure if it's available. You'll select your improvement activities based on the ones that are within that MVP, and you'll only be scored on the cost measures that are listed for that specific MVP if you meet those case minimums. Running interoperability doesn't change at all. It is the foundational level for MIPS value pathways. And the standard category weights are the same for both tracks. And if you received any of those special designations that you received with traditional MIPS, that'll carry over into your MVP reporting as well.
Okay, so if you're as a clinician, are you able to participate in multiple MIPS value pathways if there are measures that you can report in those pathways?
You are. CMS doesn't make this as clear as they probably should right now, but you can participate as an individual clinician, a single specialty group, a multi-specialty group, a subgroup, or an APM level. And the way that CMS describes this is that an MVP participant can only select and report one MVP. The freedom, however, comes from individual clinicians. So for an example, an individual clinician may report an MVP as part of one of those larger groups and also report a different MVP as part of a subgroup. You're also able to report MIPS value pathways in addition to traditional MIPS and the APP, and CMS will still take your highest score from there.
Okay, great, thank you. Now, I know that there have been some timelines proposed with CMS over the years. When is that hard stop date being forecasted for MVPs to really be that primary pathway for the quality payment program, the MIPS track, I should say?
That's a great question. Here at the REC, we are anticipating that the traditional MIPS program will be sunsetting after the 2027 performance year. That's what it's been said in previous final rules. Once traditional MIPS is no more, MIPS value pathways and APM participation will be the only ways to report. Of course, over the course of the next few years, CMS will be releasing more MVPs available for reporting that expand on different specialties and conditions as well.
Okay, thank you, Jared. So, Robin, I have a couple questions for you. In your opinion, why would somebody consider MVP participation now versus waiting until it becomes mandatory?
So CMS gave folks some options this year for, I guess you call it no fault reporting is probably the best way to describe it. So you could register to participate in an MVP, and then maybe at the end of the year, you determine for some reason that you couldn't participate, whether it's a clinician reporting issue or it's a EHR vendor issue. You wouldn't be held to that MVP, but you would still need to report under the traditional MIPS reporting pathway. So this time it's given them a little, I guess you can call it like a free chance at it and not be required or held to that MVP like you might in future years.
So what are your recommendations? What do you advise your practices to do to help prepare for that eventual transition to MVPs?
Well, they need to go out to the QPP.cms website and really review the list of MVPs that are available right now. They're really specific and they give lots of insight as to what clinician type or specialty group that it may be applicable for. So there, there's some out there now for emergency medicine, internal med, different options, and just see what's available to them. CMS is releasing new MVPs each year. We already know that with the release of the new final rule, we'll have some more. And folks just need to really familiarize themselves with what's available out there now and just keep watch for what's coming, just so that they can be better prepared for what's going to be required of them.
And well, that kind of brings me to, what are we seeing with EHRs? I know that can be a rate limiting factor on reporting.
Yeah, absolutely. So one of the things that we learned this year from a CMS presentation was when you register for that MVP, it's got an assigned number of some sort. I can't remember the right word they used, but anyway, it it ties the submission from the clinician to the MVP that they registered for. Each MVP has its own number, and then each measure within it has its own number that ties it to that particular pathway. And so vendors are actually having to incorporate that into their reporting. So when they build your file for attestation, they've got to have these identification numbers attached to the measures so that CMS knows in fact that you are submitting to that MVP that you registered for. And so vendors are having a hard time, and we've heard from several that say they're just not ready yet for this year. And so we expect that that will come with time. It's just going to take them a little bit to get caught up as well.
So I think that while some folks might be ready to start testing the waters, probably a good idea to check with your vendor first to see if they have that sort of that infrastructure built and that MVP identifier active.
Yes.
Righty. Well, thank you so much, Robin and Jared. I appreciate it. Now we're actually going to kind of transition into the different performance categories, and we're going to start out with quality. And so my questions are going to be with Alicia and Vicki. Would you like to kind of take us through the CAPS for MIPS survey? This is a survey option that's a measure that can replace one of the 6 measures. So if you don't mind to tell folks a little bit about that.
Your CAPS for MIPS is going to be an optional measure for those who participate in traditional MIPS, and then that will count for one of your 6 quality measures that you submit. It can also be used in certain MVPs, and it is required for those who participate in the APP pathway. To participate, your organization would need to meet threshold requirements, and you would then work with a CMS-approved vendor to administer a survey. And that survey is going to help gather patient experience feedback. And then to find a list of those vendors, you can go to qpp.cms.gov.
And Alicia, I want to add also, the application window has already closed for 2023 to submit a CAPS for MIPS. So to be considered for 2024, the practice would definitely need to apply by June the 30th of next year.
So definitely an important date to kind of keep on the radar if this is something you're interested in. So Vicki, I have a question for you around population health measures. We have the 4 measures that have been approved for 2023, kind of in that red box on the bottom of the screen. Are all practices automatically scored on population health measures? Is there anything that they need to submit for those measures?
So to be scored on the population health measures, you must of course meet that case minimum that is required, and there's specific criteria for each of the population measures. So unless you meet that criteria, you may not be scored. So the population health measures remember, they are based on claim submissions. So you necessarily do not need to submit anything to be scored for these measures.
I think it's important here to note as well that each of these measures is going to be scored based on your reporting level. So those first two measures on your screen are only going to be applicable to groups, virtual groups, and APM entities. And those last two measures will apply to individuals as well as your groups, virtual groups, and APM entities.
No, and I think it's also kind of important to note too, is that those population health measures actually get tacked on to your 6 measures that you've already submitted, right? So it's not like they replace any of those 6, but you would actually maybe be assessed over 7 or 8 or 9 measures for your quality category. Let's see. We have another question around just those 6 measures that the practice submits. If you are submitting your 6 measures and maybe one of them is, or maybe some of them don't align with your practice, how do you address that typically with your client?
I think the most important thing to consider here is just really making sure that all of the measures that you submit for, you can verify that you provided the care to meet that measure, just in case if there was ever an audit. So just always monitoring and validating your reports can help make sure of that.
Making it sure it ties back into the documentation within that patient's chart. Okay. All righty, so talking about scoring and some of the different designations that can offer some flexibility. So we know that CMS has retained that small practice special status, and small practices are 15 or fewer ECs tied to a tax ID. Can you talk to us about if you have that small practice designation and say you're right at 15, but then you bring on a new clinician, maybe during the performance year, does that do anything to that small status?
So a good thing is once that small practice status is assigned for the performance year, that you cannot lose that status. So that will be consistent through the end of the year. Now, if the practice reports as a group, the only impact to that group is that the clinicians become eligible to receive that group score.
Okay. So Alicia, I have a question for you, talking about some of the scoring, the points. So in 2023 was the first performance year where we actually saw that 3-point floor was removed for measures. There's always been that cushion, right, that you would get some points. Can you talk to us a little bit how this movement and the removal of that floor can impact a practice? And can you talk about how that policy applies in the context of being in a large practice versus being in a small designated practice?
Yep. So that 3-point floor was only removed for large practices. If you have the designation of a small practice, you would still retain your 3-point floor. And that would be retained for measures that don't meet data completeness, measures that are topped out, and measures that do not have benchmark data.
So now, Vicki, back to you. Thinking about the automatic PI reweight. So like if a small practice has that special designation, they qualify for that. Can you talk to us a little bit how that reweighting can impact a practice's quality score when they submit?
Yeah, if you do the PI reweight, your quality score will become 40% instead of that 30%. So that's that extra 10% of the MIPS final score. So it's really important to consider how those additional points that are shifted to quality, how they impact your overall score.
So if you maybe don't have the strongest quality performance, it's going to put more emphasis on that quality category that could bring your score down.
Yes.
All righty. And then I think my final question for you, Alicia, on this slide is, can you talk us through some of the bonus opportunities or additional points for the quality category? I know CMS has removed some of that flexibility over the years.
Yeah, even though some of the flexibility has been removed, there is still bonus opportunities available for everyone. So anybody, regardless of the size of your practice, can receive quality improvement scoring up to 10 percentage points. And that's going to be based off of the rate of improvement in the quality category performance. And then if you're a small practice, you do still receive 6 bonus points in 2023.
Thank you. So talking and kind of moving over to actual submission and attestation, can you all talk with us about some of the collection types, sort of what's the most common that we see amongst our practices, and then maybe some of the considerations that practices need to look at when they identify how they're going to submit for the quality category?
Yes, the most common collection type among our clients is the ECQM collection type. And these are your quality measures that are captured within your certified electronic health record. So these can be easily monitored throughout the year to track your performance, and you don't necessarily need a registry or a third party to use this collection type. It's within your EHR, unless there's an exception to that, unless you have multiple EHRs that would then require your data to be aggregated for submission, or if there was some other barrier to pulling these from your electronic health record.
And then here too, when you choose your collection type, you really want to start working with your EHR vendor and your advisor to look at your capabilities and just really make sure you're choosing that best fit for you. And then we really recommend that you have these conversations early in the performance year.
I think that's a really good thing to highlight. As early of a jump start as you can get on 2024, you definitely want to try to hit the ground running as quickly as you can, since we're reporting a full 365 days. Now, my final question around quality for both of you is, what do you feel are the biggest considerations that practices really need to take into account when they submit for the quality category, at the end of this year, and what they need to do to really set them up for success in 24?
So we recommend that you start by looking at your reporting level. So look at your eligibility and performance at both the individual and the group level to see if maybe one of them provides you with a higher scoring opportunity. We've talked about the collection type, but again, considering this and then having those conversations early and making sure that you validate your reports. So making sure they're correct and your data makes sense for your patient population. And then we really recommend that you monitor your performance throughout the year. So starting to look at where you have performed well for past submissions and then monitoring that performance as you move throughout the year.
And when you are reviewing that quality performance throughout the year, you're going to automatically know which measures you perform the strongest in and those measures that you don't. So you're going to know exactly which ones you need to work on throughout that year and really put some focus on trying to get that, try for that improvement. So you're in a really good place to, build that improvement over the performance year.
Now, I think, continuous monitoring helps lead to that continuous improvement, right? Well, thank you both for some of your insights into navigating this very big, important category for the program. So with that, we're going to transition over to the cost performance category and talk about some of the different cost measures and some of those calculations. And so, Jared, I wanted to start with you and just kind of get an understanding of how that cost category applies to the different tracks of the quality payment program.
Of course. So For cost, all methods are scored based on your Medicare claims that you submit throughout the performance year. Each measure is evaluated slightly different though. With traditional MIPS, there are 25 cost measures that can be attributed to a clinician or a group if those case minimums are met. Looking at MVPs, you will only be considered for those measures that are associated with that MVP and that are relevant to that MVP. You still need to meet those case minimums though. And finally, for the APM track, costs will be based on a contractual agreement between the clinician and the APM entity when that contract's signed. APMs have a little bit of an advantage where they are provided real-time data for their cost as well.
So is there, is there any other time frame that they need to consider to receive feedback, from the other submission or the other performance tracks?
So getting feedback, it's going to be about 6 months after that performance period ends. So you'll get that preliminary feedback report for cost. That's usually sometime in the midsummer around July, following that performance year. So for your 2023 performance year, look for that preliminary feedback to be released sometime like in June, July.
So there's definitely a bit of a delay as far as being able to action items in real time as far as the traditional MIPS submission.
Yes.
Alrighty, so Vance, I have a question for you around scoring of the cost category for traditional MIPS. Clinicians see the list of 25 measures, and they worry that they're going to get scored on every single measure. Can you talk to us a little bit about how that happens or what happens?
Yeah. So, all those cost measures, everyone is evaluated on every single measure. But as far as being scored on each one, it's a possibility, but usually that doesn't happen because you have to meet those case minimums for each measure to be scored on that each measure. So if you don't meet the case minimum case measures minimums, then you will not be scored on that measure.
Thank you. Jared, do you want to kind of walk us through how the cost score is actually calculated?
Yeah, absolutely. So we'll use this slide here as an example to calculate a cost score. So the first step we need to do is determine which measures meet or exceed those case minimums. This will tell you which measures you'll be scored on. In this example here, it looks like 6 case minimums were met. CMS will evaluate your performance on these measures and provide a points earned out of a possible of 10 points for each measure. And then the next step we'll need to do is sum the total of those points earned for those measures. In this example, for those 6 measures, it looks like the total is 48.5 points. Then you'll divide that by the total possible points, and that's 60 because we have met 6 of those measures. This will give you your raw score. In this example here, it's 0.8 points. You'll just multiply that raw score by the category weight. We're just using standard weight in this example of 30. So your cost score would be 24 points out of 30 possible points.
Okay, thank you. And now I want to transition over to something that's new for the 2023 performance year. Can you all talk to us a little bit about cost improvement scoring? We have quality improvement scoring, and now we have seen the introduction of cost improvement scoring.
Sure. So CMS is going to compare previous year performance with your current cost category performance. And if you've had an improvement from one year to the next, then your total cost category score should see a slight increase.
Okay, great. Now, are there any specific criteria or requirements to receive that cost improvement score?
Yeah, I could take this one, Vance. So yes, you must be scored on the cost category for 2 consecutive performance periods using the same identifiers, for both of those periods.
Okay. So one thing to also keep in mind too is that if you did not submit cost for 2022, you would not be able to compare 22 and 23, right? You have to have those 2 consecutive years.
Correct.
So now cost in a lot of cases, especially for our small practices, is reweighted. And so there are times that even individual or multiple categories might take a hardship, or they might be exempt from reporting in that category. What typically happens when those scenarios take place?
I'll take this. So the MIPS track has 4 different categories, like we said: the quality, PI, IA, and cost. And each of those have a specific category weight. And if you take a hardship or you don't meet the requirements for a category, then that category weight has to go somewhere, right? So there are multiple scenarios for reweighting that can happen. So the slide here is a really good resource that you can kind of use that shows specifically how that reweight could occur, and depending on which category is not being utilized. So as you can see, if you're not scored on cost on the slide, you'll see that your quality is in worth 55%, your improvement activities are 15%, and your PI then becomes 30%. So that's how it would affect those other categories greatly.
So Jared, I have a follow-up question for you relating to this. If a practice was trying to receive category reweighting, is there anything in particular that they would need to do to qualify?
Not necessarily to qualify, but if you are looking to take one of those extreme and uncontrollable circumstances or hardships, you'll just log on to your QPP portal and navigate over to that EUC Hardship Application Center. You'll fill out that application there. CMS will send you an email notifying you if you've been approved or not. And you'll just go into the portal, double check that's applied. And that's really all you have to do. We do recommend that you save any sort of documentation you get back from CMS with that approval, just to hang on to that, just in case anything odd were to happen.
Well, thank you both for your insight into this category. So with that, we're going to transition over to the promoting interoperability performance category. And so Robin and Tabitha, I'd like you to talk with us a little bit about the PI objectives that kind of carry the most weight in this category.
Okay, there are 100 raw points available in the PI category. The HIE objective is going to carry the most weight at 30 total points. And then the provider to patient exchange and public health objectives are runners up, and each of those carry a weight of 25 points.
And then you've got 5 bonus points that are available within the public health objective to consider. So if you've got an extra registry beyond the 2 required, then you have that option for 5 bonus points. That's the only bonus points within the category this year.
Okay. So Tabitha, I've got a question for you. So at this point in the year, right, we're kind of winding down and putting 2023 to bed, so to speak. Are there any considerations that you like to advise your practices on regarding, PI in general?
Right. So throughout the performance period, hopefully practices have been checking their progress along the way and making sure that any of those areas that are underperforming have already been addressed. I think that's a great place to start. Some other important areas are making sure that your HIE and public health objective agreements are in place. Make sure you get confirmation that your EMR is using the 2015 CERT Cures update. And also maintain screenshots throughout the year for all of the different objectives, like the PDNP query. You need screenshots just in case there is an audit that takes place after the fact. You want to have that as proof that you were complying with the program.
Okay. So Robin, I know we've had some changes with the public health objective over the last few years. Can you talk to us about some of the important things that clinicians and systems need to know about this objective?
Sure. So we've coined the phrase in the promoting interoperability category of live by 25. CMS has said that going forward, organizations can only report option 1 for 1 year for any new public health measure beginning in 2024. So the days of staying in the signed participation agreement world and not moving forward with the live connection with your registry will end. And so you'll only have 1 year of that going forward. So 2025 organizations must report option 2 and be live no later than 60 days from the start of the reporting period that they intend to use for attestation.
Right, and one more thing worth noting is that right now for 2023, the reporting period is 90 days. But CMS had proposed to extend that to a 180-day reporting period beginning in 2024. We now know that since the final rule has been released, that this is something that will be finalized for the 2024 performance period. This is going to take your first day of your final performance period for the PI category from October the 3rd to July the 3rd. So that's definitely something that you'll want to keep in mind for 2024.
So no, I think that's a very significant impact to that category, doubling the reporting time frame for it in general. So now on this slide, we're talking about just the attestation process and hardships and special statuses, right? So here, an example that we see is sometimes a group might be deemed non-patient facing, that they've met that threshold of having 75% of their clinicians with that designation. Do you recommend that they, because they do get that automatic reweighting for PI because of that, do you recommend that they submit PI, or can you talk a little bit about the benefits if they do or they don't?
Sure. So if you think that you qualify for automatic reweighting, you definitely want to verify that in the QPP portal. You know, you can check that with your TIN and make sure that it's designated as non-patient facing. So if submitting as a group, even those clinicians who do not meet the designation would still get reweighting if the group has that special status. It meets the threshold of, 75% of the clinicians there being non-patient facing.
And Jessica, for the second part of that question, clients and organizations, they need to consider that PI, what your PI score is before you can reweight that to quality, because it does reweight. However, depending on your organizational size, it could reweight to quality and improvement activities. So you want to know that if you don't have a strong quality score, but maybe you have a strong promoting interoperability score, you may not want to take that reweighting. So folks just need to really consider all of their options, not just take what's available and go.
And I think that's a good thing to point out, that reweighting is a great option if you need it, but we also have to be strategic about it, right? So another question that we commonly get is that, if a practice does use that PI reweight, right, for their, like, due to a small designation, or are they required to be on the 2015 CERT edition of the Cures Act?
So you have to be certified by the last day of your performance period for which you're attesting. You have to have the functionality in place by the start of that performance period. The final 90-day performance period for 2023, as I mentioned a little while ago, was October the 3rd, I should say. And that will end on December the 31st. So if you do not have your CERT functionality in place now, then you're not going to be able to submit for that 90-day window. So it's very important that you made sure with your vendor that you guys were operating within the 2015 CERT Edition Cures Act.
And that applies to your ECQMs as well. So while that's a full year's worth of reporting, they may not have had their Cures Act update in place. They will need to have that by the end of the calendar year just for ECQM. So if you're electing not to report PI, but you're reporting quality, you'll need to have the Cures Act in place for the reporting of your 2023 performance year.
So now here's an example of all of the 5 different objectives that we've talked about today. Under that health information exchange, can you talk with us a little bit about TEFCA? We're hearing a lot about it. How can that option be utilized this year?
So TEFCA stands for the Trusted Exchange Framework Common Agreement, and it is an option to satisfy the health information exchange objective. Its goal for TEFCA is to establish a global promoting interoperability capability. And so previously, you had 2 measures, the sending and receiving health information, that you had to report numerators and denominators, and then you've got health information exchange bidirectional, where it was just a yes or a no. TEFCA is going to work the same way. It's a yes or a no, but you have to be participating with an entity that qualifies under that trusted exchange framework and has a signatory in place for that. If you do have that in place now, you could report for this year. It would also be a yes or a no, just like the bidirectional. We're not aware of anybody yet that can do that.
So I have a question around APM participation, because I know there's been some language in the proposed rule around that. Does a practice still have to report PI if they are a part of an alternative payment model?
Promoting interoperability is one of the foundations that the QPP was built on, and it's going to be the same across all participation tracks. However, if you participate in an APM, there are a few differences.
Yeah, so some of those differences are some APMs cannot aggregate the PI data or elect not to. I think that'll change with time. So if your APM allows it or ask for it, you can submit your PI data to the APM and they'll submit it with the quality data that they submit. Or you can submit your PI data yourself and it will still be part of that APM scoring, but you do have that option to do that. And then you're scored on your performance. So there's some benefits and, some to submitting yourself versus submitting it with your APM.
Well, and that's something that we work with several clients that are a part of an ACO. And while their ACO might submit data on their behalf, they also do, it's not uncommon for them to do a backup submission to traditional MIPS.
That's correct.
And then we are also, we see lots of questions about the prescription drug monitoring program, or, kind of more commonly known here in Kentucky as CASPR. Can you talk a little bit about some of the documentation and support requirements for that particular objective?
Absolutely. That has been the question of the week. It's Tuesday and I had 3 yesterday, so it's fantastic. So a lot of folks want to know if querying CASPR meets the requirement of the measure. And so CMS is, they are not real specific how this has to be achieved. That's probably a good way to put that. It has to be completed. A query of the prescription drug monitoring program has to be conducted prior to the electronic transmission of any Schedule 2, 3, or 4 drug. And it allows clinicians the flexibility to query the PDMP using data from CERT in any manner allowed under their state law. So they don't necessarily have to have a button within their EHR that takes them out. They have to have some sort of data, which could be just a clinical decision alert tool that says, have you queried the PDMP for that measure?
Jessica, I'm
yeah.
sorry, I didn't mean to interrupt you.
No, you go ahead.
Another important consideration is making sure that practices have proof of querying the PDMP prior to prescribing to keep with their submission documents in case of an audit. So CMS doesn't require a query of the PDMP to be performed with every single prescription for Schedule 2 through 4 medications, but you have to query a PDMP at least once during the reporting period for each patient that receives a prescription for one of those medications. That's the minimum. the laws in your state may require that to happen more often. So you really want to make sure that you're up to date on the laws within your specific state.
I think that's a very important thing to highlight for sure. Alrighty, well, thank you all both so much for that. And so our final category is actually improvement activities. And I'm going to turn to Alicia and Jared to kind of walk us through a couple questions. Alicia, whenever you're advising clients, what strategy do you typically take to help them select improvement activities? And another question kind of as a part of that, can they also use the same activity every year?
We recommend that everyone starts out by reviewing the improvement activity inventory that can be found on qpp.cms.gov. The activity inventory is going to look a lot like the image on your screen, and it provides all the activities that are available, their weighting, and then detailed descriptions of the activity and the documentation you should retain. And so when you're looking through here, we really recommend that you look for activities that align with the work that your practice is already doing. And as far as using the same activity for multiple years, you can absolutely do an activity for more than 1 year that works well for your practice, but we do recommend that you come back into this inventory annually and just be sure that CMS hasn't made any changes to the activity and that the activity is still available for you.
Alrighty, and so because this isn't something that you submit, you just attest to, Jared, can you talk to us about some of the documentation to retain in the event of an audit and how long those documents need to be kept?
Yeah, so as you mentioned, Jess, you won't actually be submitting this during your attestation, but from this slide here, you can see that there are certain supporting documentation that is required to be saved in event of one of those data validation audits you talked about earlier. Documentation needs to be kept for at least 6 years. CMS has that full 6 years subsequent to your submission to come back and audit you. We recommend that you save your documentation both electronically and to print those out, put them in a binder and as a hard copy as well. To find out which specific supporting documentation you need for each activity, I will direct you back to that improvement activities inventory as well. It'll give you screenshots to save. If you certain training plans or anything like that would meet that validation criteria.
And now talking about improvement activity scoring, Alicia, can you give us some highlights on and just some overview of how the activities are scored and how practices with special statuses might be able to get some type of favorable scoring?
Yeah, so the improvement activity category is going to have a total potential of 40 category points. And then those activities are going to be broken into highly weighted activities and medium weighted activities. So for standard scoring, your high weighted activities are going to be 20 points each, and then those medium activities are going to be worth 10 points. There is some favorable scoring available for those who have special status designations of small practice, non-patient facing, rural, and HIPSA. So with these special designations, those activity points are going to double. And then your high weighted activities will be 40 points and your medium weighted activities will be 20 points. Also, if you are a PCMH, you would receive full credit for improvement activities category. But it's important to remember that if you have multiple locations, at least 50% of those locations do need to be a PCMH to receive that full credit. And then it's also important to remember that you can select any combination of activities to reach that full 40 points.
So kind of in an overview, how long does a practice or a clinician need to actually do the activity? And how many, if you're submitting as a group, how many of those clinicians need to participate?
I could take this one, Alicia. So the improvement activities category requires a 90-day reporting time frame. If you are reporting as a group, at least 50% of the eligible clinicians within that group will need to perform the same activity. They do not have to report it in the same 90-day reporting window, though. They can select a different one if they choose.
Okay. And then, so my last question is, can you talk to us a little bit about just how a practice goes about submitting for improvement activities and what they need to do, what they need to submit?
So submission for improvement activities categories is one of the easier submissions for the QPP. You're just going to log in and you are going to do a yes or no submission, and then you're going to select the activities that you participated in. So you'll just select those activities, and that is all you need to do. You don't need to upload anything at that time. But like Jared mentioned, you really will want to keep those documentations to retain available in case of an audit.
All right. Well, thank you both so much. Let's see. I really appreciate all of our panelists joining us today and talking about the different highlights of the quality payment program for this year. So thank you for sharing your expertise. If you're interested in receiving any services from us, we are here to help support quality improvement initiatives, payer-based initiatives. If you are a part of an accountable care organization or an APM, we are here to help you optimize your performance around that particular track of the program as well. So please feel free to reach out to us with any questions that you have on how we can partner together to help you navigate value-based, that transition to a value-based system, and then also to help improve your outcomes with your patients and your population. We, just as a reminder, we do have a client-only webinar coming up on December 12th. That's going to be that first rule client look in at some of the important changes and updates to the program. And then we will also offer an open to the public final rule highlights that will be made available in January. That date and registration link will be made available next month in December. So if you currently aren't partnered with us and you would like to get some information early in the year, we will have some highlights available to you. And so just let us know either way. We're happy to work with you. If you have any questions from the content we discussed today or questions around how we can best support you or partner with you, please feel free to contact us directly by phone. You can go to our website. We have resources posted there and available. And then also you can email us directly at KentuckyREC@uky.edu. We're also on Facebook. We're on the artist formerly known as Twitter. I believe it's X now. And then we're also on LinkedIn. So again, thank you all. Thank you to my fellow panelists and advisors, and thank you all for joining us today.